families for those patients that are receiving palliative care. It works through a suite of standardised assessment tools that are used at every point of contact between a clinician and a patient, and then the result of those assessments are used to determine what unmet needs there might be to drive care, and to use it as basically a clinical, daily clinical management program for palliative patients. Sitting behind the clinical program of PCOC is a data collection. So all the patient assessments that are collected by the clinician at point of contact, are then fed into a huge big data system. And then every 6 months, PCOC has a look at the data, packages it up into a suite of reports, and then gives that back to the service who submitted the data. So they're patient-specific reports. All the data is de-identified. We cannot identify anyone from your data. Your data doesn't go to anybody else without your permission, but it is used for benchmarking purposes. So when you get the reports back, there'll be the results of the service, and then there'll be the results of all the other services that participate in PCOC nationally. I think at the moment we have, Claire might correct me if I'm wrong, but I think there's about 75 to 80% of palliative care services in Australia that participate in PCOC. PCOC is voluntary, and it's also free to join and participate. So it works by improving outcomes at a service level. So as I've already mentioned, you assess the patient needs routinely. So this is a patient that has been identified as having palliative needs. Then communicate assessments with the whole MDT team. You respond to the needs that were identified in that assessment. Sitting behind the assessment form as well is an assessment and response protocol which PCOC has drafted up, because of course with every assessment there needs to be a response. So this is some of the benefits of PCOC. It's been running for over 12 years, so these are very well embedded and acknowledged benefits of PCOC. So first of all, it creates a common language. So if someone was in a community setting receiving palliative care and then they were getting transferred to an inpatient unit, for instance, a handover can be given between teams quite quickly, succinctly using the PCOC language. So what would take, a couple of paragraphs, you can really communicate in a couple of short sentences with the PCOC scores, and then you can expand on any part of the PCOC assessments as needed. You get the reports we've talked about, capability. We also have a system in PCOC where we get services to classify themselves to their capability as a service, and the reason we ask services to do that is so that when we benchmark, we can group people together like with like. It also helps meet accreditation standards. We have a whole little toolkit of quality and change tools, which is using your PCOC reports and what is illustrating your reports to drive quality improvement. So firstly, by identifying where maybe there is a need for improvement and then concentrating on that. And then you'll see the results hopefully in your next lot of reports, because it's an ongoing cycle. We also promote a community of care between all our participating services, and because we don't want to reinvent the wheel, so many services are doing so many great things and they are so happy to share. So that is actually a really big part of the program. This is a graph just showing the introduction of PCOC and how this is just addressing one of the benchmarks, which is time spent in the unstable phase, which unstable phase in PCOC means unstable phase in relation to the plan of care. So something urgent needed to be changed in the plan of care to meet the patient's unmet needs. And it just shows over time the increase in the outcomes and how well that has worked for those services. So because we know that PCOC worked really, really well, has been working really well and is utilised extensively throughout Australia in the palliative care sector, we thought, can we adapt PCOC so it can be used in the residential aged care sector? PCOC applied for and got some funding from an organisation called the Wicking Trust to move forward with a pilot to trial an adapted version of the PCOC program in the residential aged care setting. So for the purposes of this presentation, I will be referring to that pilot program as the PCOC Wicking program. Wicking because it was funded by the Wicking Trust. So what we know about residential aged care, approximately 60,000 people die in residential aged care every year. 38% die within 1 year of admission and 19% die within 3 months of admission. Therefore, by anybody's calculations, residential aged care is a major provider of end-of-life care, which I'm sure you're all very, very well aware of, which is why you're here. The other things we know about residential aged care is that there is low clinical staff ratios compared to resident numbers, as opposed to other clinical settings such as hospitals and that type of thing. Care workers call different things in different organisations, but they provide the bulk of the care to the residents. There is currently no framework that is used extensively by all residential aged care facilities to routinely assess, respond to and measure needs of residents and their families. And the full impact of palliative care in the residential aged care sector is unknown. So this Wicking program was developed by PCOC and trialled in 7 residential aged care facilities in New South Wales and Victoria. The program was designed to be led by the registered nurses, but supported by care workers, because as we've already discussed, the care workers are the ones who are with the residents every day, taking care of all their ADLs and other needs, and they are an extremely valuable source of information. So the Wicking program was developed to consist of 2 parts. First of all, it was realised that we needed to be able to, first of all, identify those residents that had palliative needs. So a screening process was developed to assist with this. And then once a resident was identified as having palliative needs, and they were commenced on the assessment and response protocol, and used that to help direct their care. So education was provided to the aged care facilities participating in the trial. PCOC improved facilitators such as myself, but it wasn't myself because it was over in Sydney and Victoria. They attended the facilities and they gave in-person training sessions. We developed quite an extensive training program targeting the different audiences. So we had one training program for the care staff and then another one for the healthcare professionals. Then during the implementation process of the PCOC Wicking Model in these facilities, there was a lot of support from the PCOC improved facilitators, both visiting in person and available by phone, email, that type of thing all the time. And we also developed a raft of resources such as manuals, information sheets and that type of thing, which were distributed out to those facilities. So this was the first part of the program, the screening for palliative needs. We developed a flowchart and went through the flowchart with each resident. So when the facility came on board with the trial, we asked them to screen all their residents to start with using this to determine which residents needed to go onto the assessment and outcomes protocol. So once they were determined that they had palliative needs, they were commenced on our usual suite of clinical assessment tools. These tools are what we use in the PCOC program, established PCOC program, which has been in existence for over 10 years. There is 5 tools, so we'll just go through them very briefly here. We have the phase. The most important thing to know about phase is it's not a phase of illness, it's a palliative care phase related to the plan of care for the patient or the resident. We have RUG ADLs, which you're all, if you're working in aged care, will be very familiar with ADLs. And we use this to determine the level of dependency of the resident and what aids were needed and that type of thing. The AKPS is the Australian Karnofsky Performance Scale, and that is to measure performance status of a resident. And then we have 2 other assessment tools which address symptoms. One is the PCPSS, that stands for Palliative Care Problem Severity Score, and that's a clinician-rated tool, and that measures symptoms in 4 different domains. Then we have, underneath that, we have the Symptom Assessment Scale, or the SAS, and this is where the patient or the resident themselves report their level of distress around 7 common symptoms. So when was what done? On admission, we screen for palliative care. So once you determine a resident through the screening process had palliative needs, it commenced on the assessment routine. All 5 assessments were done by the care staff, the healthcare professionals. they developed to make sure the care plan was appropriate so that it was addressing the palliative care needs and problem sites identified. And then the SAS tool was done every day by the care staff, and any moderate or severe scores were reported straight up to the registered nurse, and the registered nurse would do a weekly assessment of the whole 5 assessment tools. If there was any severe or moderate scores in any of either the SAS or in the weekly assessment tools, they would change to daily until such time as their needs had been addressed, the care plan had been adapted, and those scores had come down again. So, symptom assessment scale was done daily by care staff. The other 4 assessment tools were done weekly by the registered nurse, unless there were severe or moderate scores in the top one, in which case it increased to daily. Is that a question?
No.
So the way that this differed from our usual PCOC program was the role of the care staff. So as part of this Wicking trial, the care staff were trained. They were trained to collect the daily SAS scores from residents identified as having palliative needs. So to assist them with that, a SAS guide was developed which explains the symptoms, and in those cases where a resident wasn't able to verbalise or communicate how they felt about things themselves to the care worker, there were descriptions for each tool as to how they might present in a resident who was not able to talk or let them know themselves. This is just an example. This is the care guide, the guide to help the care staff. It's only got the top symptom there, but it's on a phase scale with going from absent through to severe. And then for each symptom of the 7 symptoms, you'll see, you can only see pain there. We've got patient either tells you that this is their score, as in their level of distress, resident, I should say, or if that resident isn't able to communicate, this is what the carer is seeing when they look at the resident. So the SAS scores are reported by the care staff to the nurse as per the action table, which is also on the guide. So any in the severe range had to be reported to the registered nurse straight away. Moderate scores within 30 minutes and mild by the end of the shift. We're up to number 17. What number is this slide?
I think this is me.
That's you, Claire? Yeah. Okay. I'll hand over to Professor Claire Johnson, who's going to talk about what happened next, what happened with the evaluation and the further development since we ran the trial.
Thanks very much for that, Nat. So as part of the PCOC Wicking program, we developed an evaluation of the pilot, just to be able to investigate how residential aged care facilities were implementing the program and how effective it was, and how the services felt about taking the PCOC program on board. Now, we did a mixed methods evaluation using both qualitative and quantitative data, but today I'm going to be talking specifically about some outcomes relating to the education and training, but more so the qualitative feedback that we received through focus groups and some interviews with residential aged care facility staff, who provided us with some really deep information, and which we've been able to take on board to help modify and improve the program as we go forward. As Nat alluded to, there were 7 residential aged care facilities who registered to be and commenced training for the pilot. And so we have data about the training for those 7 sites, but data about the implementation and the ongoing component of the program from only 4 sites. Can you, next slide please, Nat? And you will see why on this next very, very busy slide that our team put together. And I might add here that this evaluation was conducted within the Australian Health Services Research Institute, which is where PCOC sits, but by one of the sister centres, which was the Centre for Health Service Development. So one of the staff from that team put together this very busy document about what was done at various aspects of the project. So it started in 2009 towards the end of the year. With the recruitment and the training and the immediate embedding of the PCOC Wicking Model with 2 residential aged care facilities, Then Christmas came along, and then the bushfires, and then we started doing the education and training with the following 5 residential aged care facilities. That got interrupted by some of the aspects of the bushfires, but it was also interrupted by activities and things that residential aged care facilities were required to report and do, and the pressure that they were under from the Royal Commission. So we were just stepping into really seriously educating some of the sites, and some of them learning, downloading their IT systems that they needed, and about to go live. And March 2020 hit, and suddenly all of these residential aged care facilities that had been very keen to move forward, had overcome things that they had to do for the Royal Commission. One of these the residential aged care facilities was in an area where the bushfires impacted them. So they'd overcome a lot of those things, and then COVID and the extra things that were required, and the fear and the closing down of the services. The majority, well, all of those services did not progress. Next slide, Nat. So we've gone back and looked at the things that have facilitated the residential aged care facilities moving forward and being successful in delivery. And while we can say there were all of those things happening, there were other aspects of their readiness, or the things that they'd put in place and that we were looking for in those services and encouraging them to develop as they went along, that supported those services to continue within the program. And particularly it looked at leadership. So those residential aged care facilities that continued had leaders within the organisation who were really interested in this. They had buy-in from their executive, as well as buy-in from the staff, so they could see the importance of this. There was a commitment to putting in place local processes and procedures, so we can bring the PCOC program into a residential aged care facility, but they still needed to be able to embed that into what they were doing on an everyday basis within their facility. The orientation and ongoing education needed to be embedded in what they were doing, so that the staff who were on board at the time understood the PCOC program. They were being taught to use it in their everyday language and what they were doing on an everyday basis, and embedding it in the orientation for new staff coming on board. The other really important piece was around, and still is about data management. They had a commitment to taking on board the IT system so that their information, that their assessments could be entered into that data, and it was that they had actually identified people who would be responsible for that, not just somebody in the organisation will be, or administration. It was like Joe will be responsible for this, and so they were really taking ownership of those aspects of the program. Next slide, Nat. So just looking at the education, which is really interesting in this respect, that we trained over 202 care workers at the various sites. So we didn't just get 202 care workers in one room. There was about 14 sessions that were spread out over time. And we conducted a pre and a post survey. And there were 134 healthcare professionals, mostly RNs, who were part of the education and training, and they completed a pre and a post survey. And it was interesting to see that before the workshops, the care workers, as you can see in the table here, actually expressed a relatively high level of confidence around identifying and managing people at the end of life and identifying their problems and concerns. The health, and in fact, their level of confidence was higher than that of the healthcare professionals. After the workshops, the role reversed, that the health professionals took the information on very quickly, were confident, could see how this program would benefit them in what they were doing. Mind you, we did see an improvement in the the care workers as well, so that was very good. Next slide, Nat. So just some qualitative feedback that we found within those surveys that we did. The care workers were identifying, and they took on board that they could see that we were trying to help them give their residents a voice, so that they could be heard, and that there was a mechanism for them to be able to report the problems. That there was an actually structured approach for the care worker to be able to take that to the healthcare professional, and that there was then an expected structured response from the health that was expected of the healthcare professional. The healthcare professionals identified that it was really good that we can now care plan according to the residents' assessed needs, and it's not just caring about the resident, but we were identifying the resident and the family as the unit of care that we were targeting for this. Next one. So as I was saying, we conducted a couple of focus groups and some interviews with staff at the 4 of the residential aged care facilities who were, so the 2 that really embedded this program and are still actually involved in it, really committed to this program, and 2 that started along the pathway but did not continue because of their competing demands for their resources. So out of that, the main themes that arose from that information was about having a receptive context for change management, the allocation and availability of resources, differing attitudes, and even though those responses on our surveys about the education, it's very interesting that down the track when we were talking to places, their perception of the education and training had somewhat changed. And the other aspect was the fit of the PCOC Wicking Model into their everyday practices, so in their systems, and what we do on a day-to-day basis contributed to the success of it. Next slide, Nat. So in terms of a receptive context for change, staff felt, and particularly the managers felt, that this PCOC program was going to be help resolve some of those issues that had been raised and that they were starting to hear about at that point from the Royal Commission. The other thing that the managers were really highlighting was that the staff in these residential aged care facilities really want to do end-of-life care well. They are committed to this. So for them, this was an important program for them to be working on and to engage with. It was identified the importance of leadership, both at the clinic, at the individual site level, but as we've gone on, we've also identified the importance of leadership up, so their executive leadership. And in fact, one of the managers identified how their general program was really supportive of it. And the other comment was about how we can see the benefits of this once it's embedded into everyday practice. And their comment was, my God, this is great. This really benefits our residents. Next slide, Nat. So in terms of resources, one of the managers highlighted that as PCOC had been going and talking to the residential aged care facilities, because we do all this all the time, and we've seen specialist palliative care services put this into practice, our perception of the burden upon residential aged care facilities may not have been clearly articulated. And in fact, we may not have recognised that for residential aged care facilities, the program could be more burdensome than we had identified. And we have really taken this piece of information on board, knowing that when we're working with specialist palliative care services, this is a sector that has been utilising PCOC for 15 years now, and there's a high level of engagement and saturation of understanding around the PCOC program. Going into residential aged care facilities, they did not know about this. They were data naive, and so we were starting from where the palliative care services had started from in 2005. Now, I was involved way back in 2009, and I remember how things were within the palliative care services at that time. And we've seen such huge improvements. So I am really confident that we can do the same with the residential aged care facilities. Next slide, Nat. So we had various levels or different responses around the education and training. And as I said, this was several months after the initial training. So some people saying it's pitched at the right level to the right people in the right amount of time, right amount of time. It's really useful and hands-on. Then there's too much information for people to get their head around. That's the converse. We did have a seminar when we first started, but then we're back in the workplace and everything just changes. It seems so easy in the education session, but then you've got to deal with this paperwork. And the comment, I think if we were to be shown practically how to do each assessment would have been more beneficial. And I think this highlights that the education that we provide is didactic, and part of that and then moves into some practical demonstrations and thinking processes, so people workshop how they might respond and do the assessments. These people were highlighting that nobody was able to go in and demonstrate to them on the ground how to do it because we were not allowed to go in at that time. So the ideal is for these organisations is to be taught it, shown it, go in and demonstrate it and do it with somebody, and then get them to do it and demonstrate it to you, so that we're having that show, teach, see, do, and then teach yourself kind of model that helps reinforce what people learn. Next slide, Nat. So in terms of this fitting into what was happening on a day-to-day basis, again, there was a very varied response. So for some people, they just felt it was like ticking a box and filling it in. And we were doing it because we were told to do it, and it just takes a couple of seconds and there's not a problem. It's just another piece of paper we had to do. And that makes, like, you could question, like, how thoughtful was this? Somebody was commenting it's just double documentation, which again highlights the importance of this fitting into the program, that the residential aged care facilities, and modifying their protocols and procedures so that there's not double, and we're not, people aren't documenting the same thing in multiple places. Assessment, somebody was talking about the assessments aren't being assessed correctly. Under a minute for each one. But you're basically following what other people are doing, to be honest. You're not putting any thought into it and filling it out. And again, this is really important, because when we look at the data that comes in from the services every 6 months, we can have a look at this and see for patterns of it and provide feedback to the residential aged care facilities about the way that people are monitoring, and this might be another education opportunity, and for the residential aged care facilities to identify their champions and promote and encourage their champions to demonstrate on a daily basis how this is done correctly, and to elaborate about how important it is. And again, there's a comment about, yes, it did increase the workload, but it wasn't that bad, particularly once you got used to it and knew what to do. Next slide, Nat. So this comment reflects that once we know the routine, how to do it, it was really quite easy. And that's something that we've reflected upon, and that need to constantly reinforce and go over the steps, and to encourage services, even when they go, there's so much. That's fine once you put it into practice and you're using this on a daily basis and you're using the language, it becomes routine and part of what you do. One of the care workers was really thoughtful about this in responding. I feel like it's there, as in the resident's own piece of paper. I think about it, take it into the cottage and actually assessing them while I'm looking at the resident, not just thinking, what did I see when I'm standing back at the nurse's station and writing up my notes? I don't think it takes up much of my time, really. And one of the things that we've taken on board is this issue around time. And encouraging care workers and RNs to say, this is not new work, it's not extra work, it's what you are doing on a daily basis anyway. This is actually giving you a structure to do it with and a structure to report it. And it gives the care workers a kind of some degree of authority to be able to go to their staff and say, to their health professional and say, I've observed this. And they're reporting it back because they know that's what their framework says. And one of the, can you just do one slide, Nat? Just one of the, one of the RNs was saying, this actually fits really well into their resident of the day. So in residential aged care facilities, they every 3 months they review one of their residents, and that screening process fitted very well into that component of their what they do on a daily basis. So that's what we've tried to do, is to encourage the residential aged care facilities to think about how does this fit in with all of the other things that you do, so that they remember what to do and that it's part of that routine. Thanks, Nat. So overall, when we've been discussing this with the residential aged care facilities, they've highlighted the importance that this actually harnesses the resource that is their care workers, to be able to give them some confidence that they are being observant and that they're reporting back when they need to. It's promoted that use of a standardised way of reporting and advocating for residents' distress. And it's not just within the healthcare team. That level of communication, or the style of communication, can be used to describe to family members changes in the resident's condition, as well as being able to use that language to communicate changes in the resident's condition to other healthcare professionals. So it's really taking advantage of the care workers being available. It improves outcomes for the residents. It looks at the palliative care needs being identified earlier. We know that in some cases the palliative care needs of some residents aren't identified until really they're quite advanced, or indeed in the active terminal phase. And so we're trying to take that identification much further back downstream, so that the support and the discussions and the care that can be provided for the resident is much more proactive. It increased the frequency in assessment and timely response to those unmet needs. People were saying, yes, we're picking up those patients earlier because we know what we're looking for, and we actually know that we need to respond. And these we provide people with a framework that if this happens with your resident, this is how you respond. It has been an opportunity to inform those referral to palliative care services, and it provides awareness of the palliative care needs amongst the staff. Next slide, Nat. So PCOC developed this process and trialled it and analysed it, and it's an adaptation of the program, the PCOC program, but trying to adapt it for use within the residential aged care facilities, and we've had really good results. The feedback and the analysis shows that the care and the identification of the palliative care needs of residents has really helped improve their care. And feedback has informed that refinement of the PCOC Wicking Model as we have gone along. But we have also been in the fortunate position of being offered some funding through the Department of Health in the recent budget. So we are looking at where to next. Thanks, Nat. So this provides us an opportunity to actually take the PCOC Wicking Model, which built upon the PCOC program, and develop it specifically for aged care services. So we are setting it up as a new sister centre to PCOC, and it will be called the Palliative Aged Care Outcomes Collaboration, or PACOC. And it builds on those lessons that we've really learnt through the PCOC Wicking Model. And at the moment, we have about 30 residential aged care facilities at various stages of onboarding with the PCOC Wicking Model. They will roll over into the PACOC model, but we are not taking new services on at the moment because we're in this consolidation phase of making sure that how we move forward, we can set in stone for a number of years. Nat? Module 1. So where to next? We are looking at dividing the PCOC Wicking program, the PCOC program up into 2 modules. One of the things that we noted from the PCOC Wicking program was that the residents who weren't identified as needing palliative care, we were not able to provide the residential aged care facilities with any feedback information about them. So we weren't able to provide them with information about how their residents changed over time, their number of deaths, that kind of information. So even though the residential aged care facility was assessing their residents on a 3-monthly basis, that information wasn't captured. So as part of this, we are introducing a profile collection as our module 1, and this will be for all residential aged care facilities. As Nat highlighted before, the residential aged care facilities that took part in the PCOC Wicking program were those ones who had a good baseline level of understanding of palliative care. This provides an opportunity for all residential aged care facilities who are committed and wish to do this to be part of the program, and it provides them with an opportunity, introduces the idea of standardised screening and assessment of residents. It will provide them with data about all of their residents and the needs of those residents over time, and help them understand and be able to see the escalating symptoms and needs of their residents. And we will use this PCOC, the assessment module, the profile module, as the screening tool for residents to step into the module 2. Interestingly, we want this to align with the new ANAC funding tool that will be introduced in October next year. And so we're saying it will be really helpful if this profile assessment actually can trigger or encourage the facility to seek a reassessment for residents who are entering a palliative phase. So the profile assessment, the PCOC profile assessment, will be every 3 months, and will look at symptom severity, symptom distress, performance, frailty, and phase. Thanks, Nat. So if a resident has palliative care needs as identified by our assessment, by the profile program, they will do an in-depth assessment of their residents, start the palliative care plan, undertake the comprehensive assessments that Nat was talking about in the PCOC Wicking model. So the module 2 embeds the point of care outcome measurement into daily practice, but informs their care planning on that daily basis. It will empower the residents to actually be part of that discussion about their care, because hopefully we're identifying them further backstream. But it really provides a framework for their health professionals and their care workers to work within. So it's going to upskill the workforce, improving communication, and it will provide the module 2 will provide the 6 monthly reports, which can be used to inform quality improvement. Really importantly, this level of commitment to PCOC will help residential aged care with their aged care quality standards and accreditation, and even the services that are involved in the PCOC Wicking program have identified the importance of it for that purpose. Next slide, Nat. So this is just a diagram which sort of elaborates our recruitment and the relationship between module 2 and module 1. So individual residential aged care facilities or organisations can apply to be part of PCOC. Those sites will need to have, of course, sign off by the executive. There needs to be a real interest and understanding around the importance of end-of-life care. And then those services need to be ready to and willing to commit to being part of module 1, and that will include being able to collect the data for those 3 monthly assessments of all of their residents. Some residential aged care facilities And we know that there are some out there that are mad keen to be involved in Module 2, and in fact we have about 30 of them as part of our PCOC Wicking Model at the moment. These are the ones who will need to have a good baseline understanding around palliative care. They will need to be committed to Module 1, and we will help upskill them to step into Module 2 and to support both using that and embedding it at the bedside to inform clinical care, but also to use it for that quality improvement cycle. Next slide, Nat. So at the moment, we're listening, doing a lot of talking too, as you can see, but we're listening to services who have been involved in the program and who are interested in it. We're modifying, as you can see, we're modifying where the PCOC Wicking Model was to the next version of it. We'll be rolling over those PCOC Wicking sites in the next 6 months or so into the new program. And in 2022, we'll have a small group who will trial this starting at the beginning of 2022, and open invitations for this to be part of residential aged care service practice as from October 22. And the reason that we've targeted October 22 is the changeover from ACFI, the ACFI funding model to the ANAC funding model. ACFI requires the residential aged care facilities to evaluate or assess their residents based on the ACFI assessment tool themselves, and it's quite an onerous assessment. When the ANAC model comes in, there will be external assessment of residents for funding purposes. So it will release and free up those some of the staff to be able to commit to this kind of program. So we're looking forward to that. I think that was it, wasn't it, Nat? Thank you very much. We're open to questions if people are interested, have questions.
All right. So I have got the chat function here, everyone. I'm going to just make sure I don't, bear with me 1 second. All right, so now I can see everyone, and we've got the chat function up here. I'll just scare you all. There, oh, wait a sec. Here we go. Right, so here's the chat function. Oh, excellent, we have one person typing. So if you just go up here, I've just lost it, and you can type your message in there if you have a question. Otherwise, raise your hand with that if you want to be unmuted and ask a question. But yes, we have someone busily typing, so that's good. And I will take you off because that is a bit frightening seeing yourself like that. It's a little overwhelming. So you mentioned a readiness assessment. Is there a specific tool you used?
So in the PCOC program for specialist palliative care services, which was where this readiness tool was developed, it's PCOC specific, and it asks about and helps the residential aged care, residential aged care facility or the palliative care service to understand all of the aspects of that they need to put in place before coming on board and committing to the program. So it's around, you know, having conversations with your executive and making sure that there's buy-in from them. It's making sure that there's a leadership team within the organisation and also within the site. It's about having good conversations with people within the residential aged care facility to really motivate and ensure that they're on board. It's about planning and putting in place your education and the protocols that need to be managed and changed, and making sure your IT systems are all in place. So, you know, there's quite a list of tasks and commitments along the way.
Excellent. And so if people are interested in this, what would be their next step?
If organisations are interested in being part of the PCOC program, they're welcome to contact me, and is my email available You can find me on the internet.
We can make it available.
Just make it available. And what we're doing at the moment is we're just explaining where we are up to organisations, and then putting people on the list that we will be making contact with them next year. What should we be promoting at this stage? That PCOC is coming. It's going to help with quality improvement and a resident assessment and a response protocol. And at this point, it's still in the planning phase. It will be available next year. Is this a free service? Yes. PCOC does not charge for palliative care services to be part of the PCOC program, and PCOC will have the same philosophy, that this is something that we're funded externally to do this, and it's something that we can offer the sector to really promote improvement. But given that, we know that the residential aged care facilities, it's a commitment for them because of, you know, they need to do the training and they need to commit to those resources for data collection and actually really implementing and getting it on board. There is a commitment in terms of resources, staff input and understanding, and just to get it going. So while we don't charge, there is that commitment that's needed from the aged care facilities. And residential aged care facilities get this, they see that this is a way of being very clear about what the problems are and how to help their residents, but being able to demonstrate that this is what they're doing. And this is the change between that's happening within residential aged care now, and it's sort of part of that outcome of the commission is, you say that you do a great job, but actually where is your evidence for it? And that was something that was, a really new concept for palliative care services 15 years ago, and that's what we're introducing now.
Were there any more questions? Since we do have a captive audience, is there any chance I could put my Race PC educator mentor and get her to take her camera off and her sound off and just perhaps share about Race PC?
Of course.
Okay, this is Renata, and she actually works for PACE, and she's the educator mentor for our new program, Race PC. And Race PC, I'll let Renata describe it, but Race PC is working really closely with PCOC, amongst others. And yeah, I will pass you on to Renata. Thanks, Renata.
You go first, Renata.
Thank you. Thanks, Jess. I didn't know that you were gonna put me on the spot, Jess.
I didn't know that either until I saw you and thought, why don't I do that? I would have, put some Nippy on.
Hi everyone. I'm Renata, and I'm working with Cancer Council. So for Race PC, which stands for Residential Aged Care Excellence in Palliative Care. And I think it's just reinforcing the palliative care is everyone's business, and trying to get facilities, residential aged care facilities, to be on board with processes that facilitate improved delivery of care to residents. And then this is why I was asking about processes and what is that we should be promoting at this stage, because I've seen the great tools that PCOC Wicking has developed, and that has been used for the previous study. And it is very much similar to what is that us, especially palliative care services use in the community. And I think my question was more as well, Claire, directed to what I see is exactly as one of the care workers have mentioned about filling in a form. And and people being able to understand it's not about only filling in the form. So there's much more to that. Yes, sometimes it is that it gets onerous, but the reward of all of that work is clearly seen as well.
Thank you, Renata. That's really kind of you after I just threw you under the bus. That was harsh.
I agree, and just to let people know is that we have been talking to PACE and RACEP about the PCOC Wicking Model, and we were going to commit to doing some education later this year, but we've had to say, hang on, we've got to catch up with ourselves. We see mentors like the RACEP Educator Mentor Program as being really, really important because of that issue about being able to be on the ground to demonstrate. Now, we know that there's like nearly 3,000 residential aged care facilities in Australia, and we are not going to have resources for improvement facilitators like Nat's role for us to be able to go into 3,000 residential aged care facilities. So we have to partner with organisations like RACEP and make sure that the mentors and the people who are going in there really understand the PCOC program, so that you can help demonstrate and help mentor and show these people on the ground that how we can do this in a way that's really, really helpful for them. One of the things that we have identified is the importance of IT and making sure that we get this into the IT systems that are in residential aged care facilities. And this is something that PCOC has been sort of struggling with for many, many years, is how do we get the data that's in somebody's head and on the assessment piece of paper into our IT system. And the most effective way of doing it is to be able to do it with an app or an iPad or something at the bedside, and then to have the systems in that IT platform to suck it out so that the data can be submitted to PCOC or PCOC every 6 months. We recognise how important that is, and we recognise how important that is, especially in residential aged care, that this information can be put into an IT system once. It's done by the person who did the assessment, so it's right, and then it doesn't have to be worried about a piece of paper, you know, once a week, or the pile having to be entered into the IT system. So.
Excellent. All right. Well, I am just going to bring up the PowerPoint again, because we will leave it for now. And if I can ask everyone to kindly put an evaluation in. Like I said, you can use your smartphone. It's just simply a matter of getting your camera up, putting the camera against the QR code. It will be like it's setting up on your face, and it will open up in your browser straight to the link. I appreciate your time to do the evaluation. If not, we will be sending you an evaluation already to your email, and it will be in your junk box. So please do that. We try and sort of cover all bases. But more importantly, I really want to say thank you to the both of you coming and presenting today, and letting people know about this wonderful program which is starting. And Renata, I am in so much trouble when I see you next week. Thank you. I hope you will talk to me again after I just threw you under the bus, talk about ad lib. But apart from that, thank you. If you need any help, if you have any further questions, the PACE team are all about palliative and supportive care education, and palliative care is about working as a team. So let us know and keep an eye out for our other education. And goodbye.
Great.
Thank you.
Thank you. Bye.
Bye.